But at least I understand the content. Oh, let me just hold it. Okay, so now you can see. So maybe I will present this checklist and where maybe I got the evidence. So maybe the first thing I read through the article, but it was more medical, so I was not understanding the medicine aspect, but at least I was getting maybe what we learned. So maybe the first one was true randomization used for the assignment of participants to the treatment group. So I read through the article, and there was a section where they said that the participants were randomly assigned to the group. If you check this section of randomization and treatment, you'll find that information. And the second one was allocation to the treatment group concealed. Also, in this document, there's a section where they say that, I can't really remember the actual place, where they say that participants were randomly assigned to the two groups. So that means that so participants could fall in either group of either maybe a treatment or a control. So that's why I thought that maybe that one it had an aspect of concealing information, because maybe you couldn't determine the group that you are to fall into. Then the third question, were treatment groups similar at the baseline? So when you read through this article again, this it was yesterday, but these ones have been highlighting today morning. So it was, the old patient said, was it moderate? Let me just look for that statement very quickly. So there was a section where they said that they had similar characteristics. So the two groups, either the control or the treatment group, they had similar symptoms. So that's what prompted me to think that the treatment group and they had similar characteristics at baseline. So they were at first they had similar characteristics. Then again, the second step was now randomly assigning them into either the control or the treatment group. Then number 4, participants are blind to the treatment assignment. So this one, it was no, because there was no blinding. And when you look at the limitation section, section here, they say that the trial was not blinded because it was logistically impossible at the time of the pandemic to set up a double-blind study quickly. So that one is clear. Then those are delivering treatment blind to the treatment assignment. So so this study, one group was receiving this medication, while the other group was receiving the normal standard of care. So it was clear that one group was receiving you couldn't actually tell whether whether those delivering, so it was clear that the treatment assignment, so when it was clear that those delivering treatments, were those delivering treatment? So it was clear that there was no aspect of blinding. So that's why I say it's no again for number 5. Then the outcomes assessors are blind to the treatment assignment, where the outcome assessors are blind to the treatment assignment. So this one I looked into the entire article and I didn't see any section that talked about that. But maybe maybe you did, and maybe you can tell me.
Can I interject before we proceed so far? If the participants were blind to treatment assignment, just read the paragraph on in the method section on randomization and treatment. Then let's make a conclusion what it could be. Yes, around there.
This one. So this one that I'm projecting. Okay.
Someone can read for us.
Okay, so maybe I can just read. So participants were randomly assigned in a ratio of 1:1 to receive the TZW plus usual care or usual of care alone via web-based secure centralized system. An independent statistician provided a computer-generated assignment randomization list stratified by centers and blocked with varying blocked sizes unknown to the investigators. Okay, yeah.
So what's our conclusion? Pardon?
Because of the fact that the blocking was done and even the investigators did not know how the outcome would turn out.
Okay. Okay. So we agree there was blinding.
Yeah.
And then the second question was on, were those delivering treatment blind to treatment assignment? Oh yeah. You said no, but we said there was blinding, right? Then were outcome assessors blind to treatment assignment? On the methodology, if you move forward to statistical analysis, if you read the analysis plan, probably on the last paragraph, they say analyses were performed on an intention to treat basis with no correction for multiplicity for secondary outcomes. Thus, these results are exploratory and reported as point estimates, blah, blah, blah. So when we say we are treating the analysis is per intention to treat versus per protocol, what's the difference? What does that mean? Anyone who understands what intention to treat or per protocol means?
Maybe I can try.
Yes.
So intention to treat just means that during analysis, the groups are treated, the analysis is performed as if the groups just fall into the initial area of, any initial group of assignment. Right. For instance, if you're in the control, irrespective of whether you completed the study or not, you are still treated as still being in the control, and the same applies to whether you are in the control group or not. Yeah, so analysis assumes that you still retain your original group of assignment.
That's true. And even if you actually ended up not getting the intervention, you still be considered in the analysis, right?
Yeah.
Okay. Would that would the statisticians or the data analysts then be able to know when they're analyzing who was in which group and what medication they were given, or it doesn't matter? It's not clear. Okay. This is now for analysis. Is it clear if they knew or they didn't know who got which medication? So I'm just trying to point to us which areas we can get that information from as we go. So for this question, it's not clear if they were aware or not, right? Okay. Okay, keep going.
Okay, we can proceed. Then number 7 were treatment groups are treated identically other than the intervention of interest. So that one it was not, I didn't have a conclusive answer to that question. Maybe we can tackle it as a group, where treatment groups are treated identically other than the intervention of interest.
What are we trying to look for there? If there was performance bias, right? Yeah. You didn't get, you are not able to tell. Yes.
I concur with you, it was a bit difficult to tell because you have groups that are being, okay, the study itself, they're being treated differently. There are those who are receiving Actemra and those who are not. The ones who are receiving, of course, the consent was gotten from them, so there is some information about them and the fact that they're getting an extra medication other than the one that the team that is getting the usual treatment. So if they don't state it explicitly, you kind of feel like they must have been treated differently somehow. Yeah, so since it wasn't stated, it's even me, I found it a bit hard to tell whether they were actually treated differently.
Okay. So how do we sort out performance bias? What methods do we use to sort out performance? Because this is performance bias, right? Yeah, you want to be sure that if there were cases and controls, everyone got the same treatment. So blinding is one of the, or allocation concealment is one of the ways that you can ensure that you treat everyone, those who are getting placebo and those who are getting the treatment under investigation are treated the same. So was blinding done? We agreed that blinding was done, right? So if blinding was done, how could the people giving the intervention have treated those who are getting the tocilizumab differently from those who are getting usual care? They didn't know, right? Yes. So in this sense, as long as there was blinding and it's clear and there was allocation concealment, then you can say that the treatment groups were treated identically other than the intervention of interest. Okay.
Okay, thank you for that. Then you can proceed. Question 8, was follow-up complete? And if not, were differences between groups in terms of their follow-up adequately described and analyzed? Yes, I thought that this one was well done because in fact, Maya, was it the Maya test that were used to describe when the dropouts, the death were recorded? Yeah, and even those ones who pulled out of the study, So the study quite described that and everything that occurred. That's why I thought that it was well done. Unless there's something.
Any additions? And that's very well summarized in the study flowchart as well.
Yeah.
Yeah.
Then number 9 were participants analyzed in the groups to which they were randomized. Yeah, so the study talked about the intention to treat, and that's why I thought that participants were analyzed in their groups that they were randomized earlier.
Yes, if you check the flowchart, randomization starts with 131 randomized in 9 centers. You can just go to the flowchart so that we are all on the same. Then 64 randomized to tocilizumab plus usual care, 67 assigned to usual care at day 1. If you go all the way to the end of the chart, the analysis is done under the intervention where the participants were assigned to. Yeah, so those are some of the places you can get those answers.
So analysis were outcomes measured in the same way for the treatment groups. Yeah, I think this one is also yes, because the same statistical tools were used, and even the Maya plots shows both the two groups are being analyzed together. So for number 11, I think it's a yes, unless maybe there's an addition. Then number 11 were the outcomes are measured in a reliable way. Yeah, so the study talked about the statistical tools that were used to perform this analysis. Considering that it was a randomized clinical trial, the study used, I read the results section, and the statistical measures that were used actually answered the research questions that had been posed earlier. So that's why I thought that maybe it was a yes for outcome being measured in a reliable way.
Okay, keep going. If you have any addition, you can just raise your hand and chime in.
Was appropriate statistical analysis used? So this is just the same as 11. I had already talked about it, where numerous methodologies were used, and even they used a SAS statistical tool to analyze the data. Then number 13.
Okay, on number 12, at the start of the statistical analysis explanation, they say to maximize information from limited data generated while allowing for rapid decision. Then they say we use a Bayesian monitoring and analysis of the trial based on co-primary outcomes. So in this kind of places, you may actually need to counter-check with the statistician if there was no need for rapid decision, or there was no limited data, like what other optional more sound statistical analysis methods could have been more appropriate. And if the statistician actually acknowledges that this was appropriate, then you can actually just say yes. If not, you can make a disclaimer that, you know what, maybe the results would have changed if a different statistical method was used. Yes. Okay, keep going.
Then number 13, was the overall design appropriate, and any deviations from the standard randomized control trial designs, individual randomization parallel group accounted for in the conduct and analysis of the trial? Yeah, so I thought maybe because these maybe a test was trying to measure the efficacy of an intervention, then the randomized controlled trial design was the best choice for that task. That's why I put a yes for this.
Okay. Do we agree? Do you agree with Edwin? Yes? No? Maybe? You have a different opinion? I can hear someone whispering. You want to add something?
Yes.
Okay. Keep going. Okay. We feel like we are missing out. You're adding something to the discussion? You can bring the microphone. Edwin, kuna swali lakini haisemwi kwa... You have a question?
I think what was happening, some of us are appreciating that we started reading when he was presenting. So because we didn't open emails yesterday. But we are almost... we should have gotten some few 10 minutes to scan through before he presented. But we let progress.
Okay. All right.
I have a question, not specifically to what he has presented. I agree with his findings. Is on the consent. When I read through the article, why was the consent sought just for the group receiving the immunosuppressant and not the control? Yet you are getting results even from the controlled group. Or you don't seek consent from the control?
You do, and yeah, that's why we are praising these articles as well, because the article is talking about allocation concealment. So how are they actually able to know who was getting the treatment or the intervention to seek consent from? Was there really blinding, like the article is saying there is? Yes. So. So if you are to use this article to provide evidence to the ministry, you may want to give a caution, right? Yes, and highlight like what areas are not clear. If it was the only article that was there that was talking about tocilizumab and usual care and probably applies to your setting, you'll want to say, okay, the only evidence that is available is from this published article, but these are the limitations of the concerns we have. So this evidence may not be, we may need to look out for any other evidence that could come up in the future to make better decisions. Yes.
Okay. Then this section on overall appraisal. For this section, considering that I don't have a medical background, so maybe I was trying to question, maybe considering that this trial was done, was it in France? Yeah, so maybe I didn't know whether the same could, when replicated in Kenya, it could yield the same output. And again, I looked at the Kaplan-Myers graphs, and I didn't see anywhere where maybe they provided evidence to show that there was a difference between the two interventions, or maybe I missed that. So maybe that's why I left this section open. I didn't give any appraisal on whether to adopt it or not, based on those features. Maybe if a team member did a better job, maybe they can clarify.
You did well. You did well. Let's appreciate it. Yeah? In adult learning, every work is excellent, exceeding expectation. Sindio? Okay. Any other inputs from any of us on this? Pardon? Yeah. Exceeding expectations, I tell you. Good job. Okay, so I want to just go through a different tool and what the findings were. Then you can tell me if you are to do an assessment, a critical appraisal of this article, which of the tools you decide to take. I think this is a consult, yes.
The way the tool is
Mm-hmm.
at the end, it's also subjective where you place the article.
Yes.
Once you can the maybe scores,
Mm-hmm.
you'll be able to know outrightly
Mm-hmm.
that the article falls. That falls.
What do you mean where the article falls? Like,
Let's look at the scoring.
okay.
Stocks of
Which one?
the tool itself, HTA is saying giving useful information. It's a subjective measure.
Yeah, and that subjective measure is very important because we are appraising. So we are not going in the conclusion of the, and actually that's why I want to present what I have. Same concept, but giving comments, so that as we appraise. Remember yesterday when you were having the lesson, we said that we are not going to read the conclusion of the authors. We are going to interpret the results ourselves. Look at the methodology. Okay, did the methodology make sense? Were there gaps in methodology? Look at the results. Are the results speaking to the methodology and the objective that the study started with? What were the results? What are our interpretation of those results? And was there really an effect that was we were hoping for or not? Then you can criticize the discussion and conclusion. Does the discussion actually over-exaggerate just the one positive finding, or does it actually highlight even the negative findings that were there? And is the conclusion relevant or accurate in relation to the results that were there? So let me just...
I was wondering, for the discussion, because it's actually where you normally hear the voice of the author,
Yes.
it can make you to be a bit skewed. Is there we can avoid discussion entirely and just focus on the results? And because the discussion normally makes you a bit, it can actually skew your thinking. Because that's where the author comes out very strongly to try and support
Yeah.
the entire study.
So the whole point of appraising the article is to see that the article actually has integrity for you to use it, to quote it for decision making somewhere. So the results, you'll interpret the results may have been interpreted appropriately. If you're going to give the next level that, you know what, let's use this article for decision making, you want to be sure that the article that you're presenting on all sections, if someone just takes it and reads it because they believe you're the expert, and if you tell them this article is good and it's telling us the right thing, will you tell them to only look at the results section and not look at the discussion? It will be taken as a whole. So you want to also criticize the discussion and the conclusion. So as you're presenting that article, if it's the only one that is closest to what you're looking at, you'll present it with the subjective, with the comments that you're going to make. You say, we can use this article to make decision. The results are appropriate. We can apply it to our setting, and this is what the outcome will be in our setting. And that's why, like, if the risk ratios or odd ratios are presented, you can even go ahead and calculate the absolute risk difference, the numbers needed to treat, numbers needed to harm, all those things. So you are interpreting the findings and applying them to your setting to inform decision. As you conclude, as you're giving that evidence, you say, okay, we are using this article or published article to support this decision, but these are the limitations of this article. These were the results that were found, but in the discussion, the author seems to give a different impression from what we find in the results. Also, in the conclusion, the author may have concluded that it is safe to use this medication in only severe patients or both in moderate and severe, but when we look at the results, there was only positive outcome in severe patients, and even that outcome may have been minimal. It wasn't significant to say that, there was clinical significance. It was statistically significant, but it doesn't look like there was clinical significance. So you now give your expert opinion from your interpretation of the results and criticize. That's why you're doing critical appraisal. You criticize what the author may have written. Remember, most publications, most journals will publish positive, like something that shows, this is what is happening. And sometimes peer reviewers are not experts in that field. They are expert in scientific, scientific writing, but not expert probably in, human medicine as it is, or maybe it's someone who's an expert in plant medicine or something totally different, but they know like the structure, how a published paper should look. And there are sometimes, actually if you are published, sometimes you'll get comments from a peer reviewer, and they'll not be technical. And sometimes they actually give disclaimers that I'm not an expert in this field, but according to like the expectations of the structure of the manuscript, like the structure is supposed to be this way, you missed out presenting this bit on methodology. So if you add that bit on methodology, they will not criticize the scientific soundness. They will criticize the availability or lack of availability of information that you're supposed to give. So it's upon you as the reader to now criticize and see, like, because you're now the expert in that field and you understand the scientific details, to now criticize those findings and see what applies to your setting. This article could be adequate for someone who's making a different decision. They just want to know, okay, what else is out there that we can consider? But if you're using it for to make a recommendation, you'll interpret it differently. That's why it is okay to publish the findings that are there, because of the different levels of use. If there's just someone who's trying to find out, okay, are there any articles that have been published on, management of COVID-19 in moderate and severe patients? This is adequate. You'll say there is, you're doing a systematic review. In which countries, in which regions is there research going on? This is adequate. So different level of evidence will need different level of details. Yes.
And also, if maybe your plan is to reproduce the study as it is, I'm just wondering, in that case, would you also consider your comments, because you've been able to appraise the entire study, so you actually feel that perhaps it could have actually gone this way, or would you, in that case, just have to stick to actually the study itself, and maybe ignore
I think the next presenter is here and she will kick me out of here. But I did an appraisal with one other tool. So I want to show you. It will answer what you're asking. So you want to look at the validity, the results, and the application, right? So this tool has a few questions. For example, if patients were randomized, and I say yes, participants were randomized, randomly assigned 1-to-1 ratio. Was there randomization concealment? Yes. And independent statistician provided a computer-generated assignment, randomization list, and blocked with varying block sizes unknown to investigators. You see, this one gives us even like a section to make comments. So you can actually pick, like you give evidence from the article of what happened. Were patients analyzed in the groups to which they were randomized? I said yes, and I gave the figure. From the flowchart, you can actually tell they were analyzed in the group they were randomized in. Were patients in treatment and control group similar with respect to non-prognosis variables? Then, when you look at the patient baseline characteristics on table 1, it gives you the similarities in baseline. Sawa. Was follow-up adequate? We say out of the 131 assessed for eligibility, 64 to the intervention and 63 in the control group or the comparison group. So 67 to the usual care. And out of that 67, so from the allocation, we only lost one person in the toxilizumab group, right? Out of the 64. And for the usual care, everyone was given usual care was analyzed. So we said the follow-up was adequate. So yeah, these are just shows you like the things I'm mentioning in the other table. And then this talks about blinding. So I think I've also highlighted the randomization of treatment, why they blinded the patients. So this is what he was highlighting. That is, I've highlighted there. And then, was prognostic balance maintained as the study progressed? So were patients blinded to group allocation? Were clinicians blinded to group allocation? Were outcomes assessors blinded to group allocation? Most cases, the clinician taking the decision of ventilation assistance was from another department, from the enrollment group. So that's why I said no. And there's a query about performance bias in this instance. And I think I've highlighted where that came from. So these slides, I will share them, so you'll be able to interrogate them. And then, so what were the results? So for primary outcome, you remember yesterday we were talking about the different level of outcomes. So primary outcome was a score higher than 5 on the WHO 10-point clinical progression scale, and survival without need of ventilation. For secondary outcomes, the WHO score at day 7 and 14, overall survival, time to discharge, time to oxygen, supply independency, and biological factors, which are actually, this is composite outcome, the C-reactive protein level, and adverse events. And I've highlighted where that is in the article as well. Then estimating the size of treatment effect. So for this, I think these ones we looked at yesterday, the different treatment effects that we could talk about, relative risk, odds ratio, number needed to treat. But I did a calculation from the results that were reported for us to tell how large the treatment effect was. And I calculated number needed to treat. And it's a negative. So was the treatment effect clinically significant for us? Yes, no, maybe? No. If you remember the definition of number needed to treat, then you should be able to interpret this. So when we are given just the figures and we calculate the relative risk differences, we may end up with conclusions that are not really informing. But for this, we actually we don't gain anything from using this medication in this group of patients. When you look at the relative risk difference, it's negative. Survival without need of ventilation. If you look at the relative risk, okay, there seems to be some significance, but I'm trying to see the confidence interval doesn't give as much. Okay, for relative risk difference, at least you can tell there's a difference of 15% and it's statistically significant. How precise was the estimate of the treatment effect? Number needed to treat, you need to treat 6 patients to be able to realize one patient to benefit from that treatment. So for every 6 patients, you'll see a positive outcome in 1. And that was statistically significant. Okay, then how can I apply the results to patient care? This is the part that wasn't very clear in the other article, right? So were the study patients similar to the patients in my practice? So I highlighted this for us. So patients were included, and then they tell us patients with moderate, severe, or critical pneumonia were included. So you want to ask yourself, do you want to answer this question because you're considering treatment for moderate, severe, or critical pneumonia, or are you looking for this treatment for something else? Like patients with COVID-19 and have moderate, severe, or critical pneumonia. So if it's the classification for your patients in Kenya are similar to this classification, then you'll say you can apply this study because of the similarity in patients. Then were all clinically important outcomes considered? The clinical status assessed with the WHO score. There was overall survival, time to discharge, time to oxygen supply, biological factors. You can highlight what other information you'd have loved to be here that was not here. So for me, I highlighted cost analysis was not done. So we are not able to tell if we include this intervention, is it cost effective compared to the usual care? Will there be cost savings, or what will it cost us to include it? Are the likely treatment benefits worth the potential harm and cost? So, so there's clinical, okay. So in the article, they say the usual care level, it reduced the level by reducing the need for intensive care, which is known to increase the risk of long-term complications, eventually death, and decrease health-related quality of life. So tocilizumab use may limit the burden on ICU. And that's why above there I said we needed cost analysis, because we want to be able to tell, like, is this treatment benefit worth investing in? If we are saying we are reducing need for intensive care, how much are we saving from that? If we say we are decreasing health-related quality of life, how much qualities are we gaining from this, introducing this medication? Yes. Yes.
What it means to have a negative number. Does it mean that
for this group, and I think I must have got this information. You can counter check for me. I must have got this from because analysis was at 2 levels, day 1 and then follow up at is it day 7 or day 14? So this must have been like the initial results. So at day 1, you are not really seeing any significant effects of this drug.
But if I calculate and I find it's negative, what does it mean for us?
It means that the comparator is more beneficial for that patient. Yes, I actually have an article that guides on interpretation of number needed to treat as well. I could share that with you. Please remind me if I don't, so that you explore. And even there's really no point at which you'll say, okay, like if number needed to treat is 3 or 10, then that's good. But there's a pointer to what you can consider as at least, like if number needed to treat is 5 and above, okay, it makes sense. But it will vary with the medications and the prevalence of disease as well. So that article explains that really well. I'll share it with you. And then Paula is here. Are you ready to take over? I was just giving remedial classes as we went. Just let me 2 more slides, and then I can take a question. So from the authors, so I highlighted the author's conclusion and then my conclusion, and we can criticize both. So for the author's conclusion, in this randomized clinical trial of patients with COVID-19 and pneumonia requiring oxygen support but not admitted to the intensive care unit, tocilizumab did not reduce WHO score lower than 5 at day 4, so early. That was the conclusion, and you can't tell that from the results unless you do these extra calculations. When you do these extra calculations, you're like, okay, it doesn't really make sense, right? Then when you go to the conclusion, you actually say, okay, yeah, the author also realized that there was no significant lowering of the score in at the early results at day 4. the first initial analysis. Tocilizumab might have reduced the risk of all those complications by day 14. So when it's used over a longer period of time. There was no difference on day 28 mortality found. Further studies are necessary for confirming these preliminary results. Haya, mimi kama reviewer ni nani? Mi pia nikapeana opinion. So tocilizumab was beneficial to patients with inflammation, showing decrease in levels of C-reactive protein. Remember that was highlighted in the results. Hence, it explains why it was beneficial to the 60-year-old male patient. So this was like the patient that we were working with. You remember yesterday when we were doing literature review, we came up with a research question, yeah? So the patient had increased interleukin-6 and pro-inflammatory cytokines. So outcomes, the clinical outcomes, we have the main outcomes that we're looking for. We have the surrogate outcomes, we have the composite outcomes. So you'll find some articles will highlight things like this and say this medication is beneficial because this patient had elevated or deranged lab results, and when they were given this medication, those deranged results became normal, reduced. But overall, we are not seeing like the real benefit of the medication. So beneficial effects of tocilizumab is observable over a longer period rather than short term. That was the reviewer's conclusion. That is what. So it means that this study was done over a shorter period of time. It could have needed to be done over a longer period of time to see what benefits there are. And they actually give disclaimers. They needed to make rapid decisions, and analysis started way before they actually had adequate data as well. So in conclusion, as you do critical appraisal, you need to check both the internal and external validity of the results, estimate the treatment effect using the relative risk ratios and number needed to treat, because it will give you more information and a clearer interpretation of the results than what may have been represented in the article. And you also need to assess the publication of the results and its application to patient care. That's all from my end. I hope you enjoyed that session, and it is very applicable to you. Any questions as Paula comes? Paula, you can come. Are you able to join the Zoom?
Yeah, can you send me the link?
All right. I'll take any questions.
So like now if I had several researches like these ones, and I brought like 10 together, I could even be able to make more decision now, combining the results of that similar.
Yes. You remember the 23?
Yeah.
Unaweza overdo. Yes. So you can critically appraise and decide, okay, which one actually gives better evidence that you can then forward for decision making. Do you want
Okay,
this
you
or
tell me
this?
how to do this. What's it? That one is probably easier.
You can
I'll probably not hold it.
Or you can log into Zoom.
Yeah.
I've sent the email. Or do you want me to
Email?
just give you the
No,
link?
I should get it right. You send it on Sema.
Yes. All right. Let me give you the. Yeah. You can go to the. Just join meeting and the meeting ID.
want me, then that's why I printed on my notes. Okay. You're so organized. Where do I put this? Just here?
Yeah.
Okay. Learn more from you than you're learning from me, and I think this session over the next, I would say, 45 minutes will give you a primer into some of the basic economic evaluation tools and methods, and I think you can use these slides as a reference point in the future whenever you need to go back and try to understand some basic principles. What we will cover today are the concepts of economic evaluations, what they are and why we do them. The four main types of analysis, the types of decision models, and the synthesis of evidence from decision models. You're going to go into a lot more content and depth on each one of these topics throughout the day, but I do appreciate any questions. If you want to ask questions during the sessions, please go ahead and just raise your hand. Happy to ask them while we cover them. But I think some of the tools you will actually explore more with Tabitha later on. So I think, as you have figured out in the last few days, and know from your profession, there are many interventions that are effective and worthwhile that could be used to improve the health of a population. And if we had an infinite amount of money and we wouldn't have any limited resources, we would probably spend all of the money on every beneficial health program that we could find. But in reality, that's not the case, and we have limited resources, finite resources, and if we were to choose to spend all of our money on only one health intervention, then we would miss out on other ones, which is what we would call an opportunity cost. Because of this difficult decision-making process, we have to ensure that the limited amount of money that we have is somewhat spent most efficiently and effectively. So this is the backbone of economic evaluations, and I think it's a dilemma that you will face on an everyday basis. In economic evaluations, we only look at two main components, and today you've already had a revision session on health outcomes. In addition to that, we have costs. You basically outweigh the costs and the consequences of an intervention. Say, for example, you have an intervention that we rated in stars, has 2 stars in terms of health outcomes, and is mediocre expensive, medium expensive. Another intervention is a lot better maybe for the health outcome, but also a lot more expensive. So what do you do? And you want to basically find the relevant tools to be able to compare the 2 interventions or more based on their costs and outcomes. This is the basic way of comparing any intervention with a comparator or base case scenario, where we always compare the difference in costs of a new and old practice with the difference in outcomes, health outcomes, of the new and old practice. This basic equation is, again, a backbone of economic evaluations and is how we would perform any economic evaluation. But let's just take a step back. We have something called partial economic evaluations, which you will never do in health technology assessments. Why is that? You would only do a partial economic evaluation if you only examine the costs or consequences of an intervention independently. As you have learned over the past 2 days, you would always want to consider health technology assessment tools when comparing multiple options, yeah? But you can also do a partial economic evaluation to examine both the costs and the consequences of an intervention, but only evaluate a single course of action. This is something you would call a cost outcome study. Now, I am not going to go into more detail on partial economic evaluations because really this is not what you will ever do. Because you don't compare the focus on analysis is not on comparing to any other policy or intervention options. Instead, what we want to do is a full economic evaluation. Those are explicitly comparing the costs and consequences of a health intervention or more health interventions to an alternative course of action. This is what you would call a comparator. Okay, a comparator, this is a commonly used term. You would also maybe know it as a counterfactual or a baseline scenario. This is typically chosen to reflect the standard care of practice. Say, for example, you have the HPV vaccine currently introduced in 2019. It's a 2-dose vaccine administered. At the moment, I believe it's in discussion to bring a 1-dose vaccine into the policy. So your baseline scenario would be the 2-dose vaccine in this case. Formally, you would always evaluate at least 2 alternative courses of action. And even if we didn't have a standard care of practice and you have a new intervention that you want to introduce, you would compare it to a do nothing or no intervention scenario. So you always have a comparator, a baseline scenario. Looking at this hypothetical example here, I just want to make sure that you will never use a partial economic evaluation. You would find that the benefits of a new treatment, so the monetary value of its health benefits, would outweigh the costs. So if the costs are lower than the benefits of it, naturally we would want to introduce it as a policy. Yeah? Makes a lot of sense. But when performing a full economic evaluation and comparing the treatment to the current standard of practice, the analysis would actually find that the new treatment is less effective and more expensive than the current way of doing things. So we would decide for the opposite policy. Henceforth, when relevant alternative policy options are not considered, so for example the standard practice of care, and they would be ignored, analysis would generate a misleading conclusion in the policy. So there are a few topics that I just want to touch on, but I think further lectures down the line today will go into more depth on these topics. We need to be considerate of the different types of costs when costing an intervention. We have direct costs, indirect costs, and intangible costs. I feel like those names are somewhat self-explanatory, but there are further sub-considerations going into each one of them. Direct costs are costs that are, as the name says, directly related to an intervention. So say, for example, the cost of x-rays, the cost of equipment, the cost of staff, healthcare staff, or the cost of transport to a healthcare center. The direct costs are normally the main focus of analysis of any economic evaluation. Indirect costs are associated with the reduced productivity. You might be familiar with these concepts, so apologies if I'm repeating what you already know. But these productivity losses would be due to the illness or the treatment. So, for example, you would experience missed wages because of not working due to the illness. And finally, the third part would be intangible costs, which are very subjective and very difficult to measure. Say, for example, the cost of grief or the cost of stress or pain. It's very difficult to put a monetary value to this. Henceforth, not all economic perspectives would consider the intangible costs. I mentioned the word perspectives. That is something you have to decide on at the very beginning when starting an economic evaluation. Why? Because the perspective defines which costs you would want to consider and which ones you would, and how you would value them. So the choice of perspective is linked to the objective of your research question. Let's go through the 4 examples we have here, and those are the most commonly used perspectives. The payer perspective includes all costs that are incurred by a specific healthcare payer. Say, for example, a specific insurance program or an agency that has an insurance program, as well as a specific control program or a healthcare organization that has one specific program or policy agency in one specific matter. These costs would include anything that the healthcare payer signed up to pay for and that is related to the specific disease management. So let's say, for example, you have private health insurance. My private health insurance doesn't cover dental costs. So if my treatment would be dental related, I would not be covered, and this would be patient costs. They would not be covered by the payer perspective. So any out-of-pocket payments by patients would not be absorbed in this perspective. It's also important that the payer perspective only relates to the part that is actually in the contractual agreement. So normally it's quite specific what a payer pays and what the patient pays. Then the second one is the provider perspective, which is somewhat similar to the payer perspective, or it can be, depending on the setting on where you are conducting the study. Those are basically costs that are assumed when delivering any healthcare services to the patient. The key difference between the payer and the provider perspective is the context of the study, but it is plausible that the provider perspectives will be the same, but giving a more complete or more comprehensive picture of the total costs, and is more commonly used in costing exercises than the payer perspective. Finally, the patient perspective, or also known as the household perspective, this is normally defined in study settings, are used to describe the costs borne by an individual or their households. So as I had already mentioned, we have an insurance program, but somewhat there are always costs that come up for the patient as well. Let it even be the indirect costs, right? Like the transport to a healthcare facility, they are never covered by a healthcare insurance. So it can also, depending on the context, include direct medical costs, out-of-pocket costs, co-payments, deductibles. Deductibles, I'm not sure if this is common in Kenya. It's like the excess that you pay for your insurance. So let's say, for example, you want to raise a claim, similar to a car insurance. You want to raise a claim because there is a damage to your car. You need to pay somewhat of a premium so that you will be able to, it's like a reimbursement, yeah? So it's the same thing, that is your contribution basically, and from a patient perspective, those costs would be incurred. And then finally, the potential productivity costs. So those are known as the indirect costs, as I had already mentioned, which are the monetized productivity losses due to the lost paid or unpaid work. And finally, you have this gray shaded area here. This is the societal perspective, which is the broadest and most comprehensive of all these perspectives, and it covers all of the healthcare related costs, regardless of who is paying for it. So that covers the patients, caregivers, the healthcare system costs, anything that you could think of. And they can even include other relevant costs too that have a spillover effect on other sectors. Say, for example, environment, legal, justice, social services, and so on. As a nice reference point, I think, in the future, you might be wanting to get back to this diagram, which has a nice overview as to which costs are covered in which perspective. This paper on the bottom right, this is where I took this table from. I think you can also refer back to this if you want to understand more about these perspectives. Now let's go into the 4 main types of economic evaluations, and they all marginally differ in their abbreviations, which is why I'm going to go through the names first. The first one is the cost minimization analysis approach. Second one is cost effectiveness. Third is cost utility. Fourth is cost benefit. They all differ in the way that we define the health outcomes and the costs. Those are the two components of economic evaluations. Let's start with the minimization. Say, for example, that you have a medication that has the same efficacy, the same effectiveness, and would go on the market. So the only way that they actually differ is the cost. In this example, we would go for the orange bottle because it's priced at only 200 bob. Yeah, it's very, very clear. To be honest, cost minimization exercises are rarely used in health technology assessments, but you want to be aware of this method. Then the second one is, let's say we have a common outcome, but we have different interventions that lead to the health outcome. Say, for example, you have an intervention that reduces blood pressure, another one that avoids cancer cases, another one that reduces your weight. Another one is the years of life that you gain in general. All of these are called natural units. Again, I think this will be covered in a later session today. But they all have common outcomes. And this is what we call, in terms of the cost that you would benefit from this intervention, is the cost per life year gained, or the cost per case detected. We will go into more detail in the cost effectiveness analysis approach at a later point. But what do we do if we have interventions that all have different outcomes? So say, for example, you see this diagram here. To be able to make a recommendation to find to decide on which interventions to allocate resources to, we want to compare them, but need to find a common measure that allows us to compare all of these interventions. Before I go on the next slide, can anyone think of one measure which you have actually covered in depth already in the last 2 days that allows you to compare multiple interventions?
Clinical trial.
Let's think of a health outcome measure, or an outcome measure from an intervention that allows you to say, that's a method. So these are, what you mentioned now, these are methods that either allow you to evaluate the effectiveness or synthesize data streams. We want to find a metric that it says, okay, we choose A over B, or we choose a mix of A and B. Let me give you a hint. So with every intervention that we introduce, we want to prolong the life of a patient. Does this ring a bell?
Yes.
What's the other component?
Quality of life.
Yeah, so? Qualis, exactly. How's the quality of life measured?
The number of years lived without the suffering.
That's right. That's the quality adjusted life years. But quality in specific, you're going to cover this in a specific session later today, is a value from 0 to 1. You just try to measure it, and then you multiply the number of years with the quality. This is how you get your quali. You're going to cover this later on, but I just want to make sure that this is, you know that cost utility is associated with qualis, or alternatively, the other one? Yes, thank you. Great. Yeah, okay, cool. Yeah, so as I mentioned, there are tools on actually evaluating the quality of life. Tabitha is going to cover this. There are survey tools which are referred to as EQ5D, WHO, QOL. You will cover this later. Then the fourth one is a method in which we consider both the cost and outcome measured in monetary terms. That is the cost-benefit analysis. So here we want to account for all costs and all benefits. It's also arguably the most, while it is the most comprehensive type of economic evaluation, it does require, it's quite hard to get the right data for it, and there are methodological issues in determining the value on life and productivity. There are two approaches commonly used to determine health outcomes in monetary terms, which are the willingness to pay method. So that is the value that people attach to health outcomes. So you would ask how much people are willing to pay to have the benefits of the treatment or to avoid the cost of illness. The other one is the human capital method, which places a monetary value on the person's life. And the value is based on the loss or gain of income due to illness. Okay. Then you have covered some of these methods already. As you said, clinical trial. Yesterday, Jeanette had given you an introduction to pragmatic trials. Along these, you can measure the efficacy and the effectiveness, so the health outcome of the treatment. And you can also measure the cost. In these two first cases, they are associated with some limitations in terms of the number of comparators. So in a new interventions, we might not be able to have that many other alternatives to compare to. And the health outcomes are arguably intermediate. Say, for example, the first time the HPV vaccine was introduced, at the time of introduction, I think in Europe in 2012, the long-term health outcomes were still unknown. Those were actually only valued in a couple of years ago. So it takes time. An alternative method, which SEMA is an advocate of, are decision models, in which you would collect data and synthesize data from multiple sources to summarize the costs and the effectiveness or efficacy of an intervention. You do that through meta-analysis. You can also collect primary data through surveys. You might have existing databases. You might tap into pharmaceutical databases on the costs of a treatment. Yeah. And I think Daniel had mentioned this argument already, garbage in, garbage out. Your result is only as good as the data and the model. So we go into this a little bit more, but you need good data, and you need to adjust data if they are coming from other countries to your local setting. Nonetheless, decision models, we use them to be able to predict the future and to somewhat reduce uncertainty. I can say for a fact that no model is perfect, and there is a lot of uncertainty, because in every data point that you supply to the model, you will have some form of limitation in the data. It's not comprehensive of the entire country. The model is only covering one county, maybe. Then the policy recommendation you would take from that is not necessarily applicable to other ones. But it does allow you to evaluate the consequences from adopting a health intervention or technology. And specific to your research question that you posed at the beginning, every model can be tailored to the specific purpose. And finally, let's say you have a lot of information. In a decision model, you are able to synthesize this data. Now, I assume that none of you are modelers, which is okay, but I think in simple terms, every modeling approach works as follows. You have input parameters, you have a model, which let's call it the black box, which you're going to go into more detail at a later point today, and you have the outputs. At the moment, we want to focus on the inputs and the outputs. The modeling comes at a later point. The benefit of decision models is that it allows you to use information on transitional probabilities. That is, for example, not everyone is affected the same way by an intervention. Yeah? I might react differently to a medication than you do. A female might be reacting differently to an intervention than another one. So these are transitional outcomes of going into a next health state if an intervention was introduced. It allows you to synthesize costs. and outcomes that we have already discussed, and other relevant variables. So for example, access to care, access to an intervention, behavioral data, there are many more. And you can use this to run a cost effectiveness analysis, budget impact analysis, and I want to stress this, an uncertainty analysis. Sometimes you read a sentence and say, a vaccine will lead to 20% increase in survival rate. Well, I can tell you that that's not possible. We don't know 20% for sure. We need an uncertainty interval to convey that there are limitations to whatever data you have. So if you see a point estimate, I would always question it. Okay, so just going back to this, decision models in healthcare are really only as good as the data that you put in there and the modeling approach. Now, you might not be modelers, but there are a lot of modelers. So in using decision models, you might always want to ask an expert for their advice. But it comes down to the capability and capacity to actually evaluate the evidence that you receive from those models in health technology assessments. No one expects you to program a model, but if you will be in a better position if you understand what the input variables are and what the outcome is. Two key considerations before we model are the cost adjustment and time horizon. Two components which I think are very logical, and you will see why. So let's say we did an economic evaluation this year in 2024, but we only have data available from 2020 on costs, which is very reasonable. Then we need to adjust them for inflation. As you know, inflation is very volatile, and the markets are very volatile. And you would, to adjust for inflation, there are different methods that can be used. But you want to make sure that a rigorous evaluation adjusts all the costs to the base year. So in countries where prices are relatively stable, you can use the local prices and the local currencies, and you would adjust those using local inflation rates, and then report the adjusted costs in the local currency. That is mostly the case in middle and high-income countries, but in low-income countries where you have volatile markets, the prices or costs of resources are fluctuating a lot. So what you would commonly do is that you convert the local prices to a foreign currency, normally US dollars or international dollars. US dollars are a little bit more intuitive. International dollars are good for global comparisons, but no one can really interpret them. And you would then use the US inflation rate. Okay, and the other one is the discount rate. So let's say, for example, that we want to evaluate, I'm coming back to the HPV vaccine because this is what I wrote my PhD on, but it's my favorite example. You have the HPV vaccine today. The benefits are only actually incurring over a long period of time. Only when a girl is vaccinated when she's 20 years old, when she's 10 years old, she may or may not get cervical cancer at the age of 30, 35. So there is a lag of 20 years, 25 years. And this is only when the health system benefits of the intervention might also be felt. Yeah? So if you wanted to project the cost savings over time, you have to consider that the prices would actually increase over time as well. This is when you adjust all costs and cost savings through a discounting rate. Normally, and these vary by country, discounting and inflation rates are 3 to 5%. As I had mentioned, the time horizon of an intervention very much depends on when health outcomes are felt. So when you start a modeling process, you always want to define the time horizon to calculate the outcomes and costs. And so this is what modeling approaches are very good for, because you will be able to tap into the future without actually measuring anything in the future. This comes with a lot of assumptions, but it will allow you to see foresee the consequences of an intervention. Good. Okay, so we have 3 main types of decision models in healthcare that we're talking through here. The decision trees are basically a diagram that shows you the risks of events and the stated nature over a fixed time horizon. So I just want to, here as an example, you have a screening policy decision, then you would go into a screening or no screening. Then, let's say no screening, you might be infected or you might not be infected. To each one of these branches, you put a probability, and that is what you would call a decision tree. This is the simplest decision model that you would find. Whereas a Markov model is basically the repeated decision trees over time, many times. You would look at this at a population level, and thereby you can simulate a hypothetical cohort of individuals through a set of health states over time. The third one, which is what I'm most passionate about, but they are also more complex, are dynamic models. They are somewhat similar to Markov models, but they allow for the interaction between individuals. And this is an example of, I don't know how it was in Kenya because I was in Europe, but in Europe, all of the COVID-19 models were dynamic models or agent-based models, but mostly dynamic models. This, again, I think is a good table summarizing when to use which model. The decision tree models are used when the time horizon is short and fixed. And you would look at, for example, an acute intervention with no recurrence. So someone would only have to be treated once and quite imminently. Whereas Markov models can be applied for diseases or conditions that involve risks over a long time horizon or recurrent events. So you might be going, you might have, okay, I'm not sure which intervention it is. Let's say this is an intervention, you have a success, then you have a revision, then you have a success, you go back into revision. So the modeling approach does allow you to go back into other states over time. I think you're covering Markov models later on today as one example of a decision model and learning how to actually apply it. And finally, the dynamic models allow you to consider behavior or contact behavior in the population. So that's mostly the case for infectious diseases. I like this diagram because it walks you through all of the steps in defining your model, and we'll go through it very slowly. But I think you can use it as a nice reference point whenever you want to either commission a modeler or try it yourself. So you begin with specifying the decision problem. Maybe through a literature review, you've identified a research question yesterday. So this is your starting point. You're defining the decision. You're trying to understand what the disease of interest is that you're looking at and what the interventions are that are of interest. And what should we compare to? So is there already a standard practice of care? Or is it a new technology? Are we comparing it to no intervention? Then, in the second step, we're defining the boundaries of the model. Here we want to understand what is the objective of our analysis. Is the aim to evaluate DALYs? Is the aim to evaluate QALYs? Respectively, we want to decide what decision models of the 3 that we have seen now do we want to use. What outcome measures are we interested in? What is the targeted population? The targeted population might be defined, for example, by socioeconomic status, by age, by gender, by geography. You might only want to look at one hospital setting or one county, or you want to look at an entire region of Kenya, or Kenya at large. And which perspective should we perform this analysis in? Can someone remind me which one is the most comprehensive perspective of economic evaluations? Great. So in most cases, you would do this if you have enough information, but you could also give me one other example of another one. Any other one? Payer perspective could be an alternative. So in this process, you want to be very determined as to which perspective you're taking, because the costs that you will include in your economic evaluation are determined by the perspective that you've chosen. And then finally, as I had mentioned in the previous key considerations, is the time horizon over which you want to perform the analysis. So is it a short term? Is it a medium term? Is it a long term? How many years, month, days, what it is? In this process, it is very useful to talk to people. Maybe potentially already in the first step, specifying the decision problem. But at this point, in defining the boundaries of the model, you can speak to experts. Doctors will have a lot of information and knowledge on the possible outcomes, on the time horizon. Whereas, let's say, you working more with pharmaceuticals have a lot of information on what costing data is available and what perspective is reasonable to take. Then we synthesize the evidence through cost-effectiveness analysis, for example. I'm going to show you an example of this after this. And then, as I mentioned before, we don't want point estimates. We want to perform sensitivity analysis. So, for example, you have one medication and you have a lot of different costing data. Then you would have a minimum and a maximum. The simplest uncertainty, a one-way sensitivity analysis, would be just changing the costing data. So you would do the entire analysis with the lowest cost estimate and the entire analysis with the highest estimate. That will give you an upper and a lower bound. Okay? And finally, the model utilization. And I think this is where it becomes interesting, because models can be used in various ways in informing decisions as evidence. For example, they help to set prices, and they define the value added. So I think Daniel gave a great presentation showing that you need facts. When you go into discussion, you need facts. So through an economic evaluation, you have those facts. And you can say, compared to not doing anything, this is what we will benefit, yeah, in terms of costs and in terms of health outcomes. So effectively, you will determine the value for money of health interventions. Now, looking at the diagram on the right, conventional pharmaeconomic analysis. So pharmaeconomic analysis is basically a fancy term for economic evaluations in this case. Yeah? These analyses of new drugs are usually performed at the end of phase 3 trials. But really, the moment that you learn about a new intervention, you want to start collecting your data on costs and outcomes and try to perform this analysis as early as possible to determine the price and to set the cost for the market, which basically helps you longer down the line in terms of the research and development decisions of the pipeline. Okay. Now, evidence synthesis. We're going back to this original formula, which is basically defining the incremental cost-effectiveness ratio. I'm just going to walk you through it in simple steps because I think you will come back to it throughout the day today. But I feel like it's fairly straightforward. We have a standard treatment, which is our comparator baseline scenario. This is A. And we have a new treatment. This is B. For each one, we have a cost and we have a health outcome. Yeah? In an incremental cost-effectiveness ratio, we have we take the difference between the cost and we take the difference between the health outcome effectiveness. That will give you a ratio. And you can compare this ratio to a threshold. I think Tabitha mentioned yesterday that there is no standard DALI value or QALY, right? Threshold. So I found one in the literature, which I don't think is a great example, but it was a global analysis trying to determine a threshold value for all low and middle income countries. Kenya was part of this, and they determined a threshold value of $919 per DALI averted. That translates to approximately just less than 50% of the GDP per capita in Kenya. Yeah? I'm mentioning this now because we are going back to it in a second, but it's useful to know that there are threshold values. I think Kenya still has to define what this threshold value is, but you want to test your cost effectiveness. You want to compare your cost effectiveness ratio against a threshold value. So this is somewhat a starting point. Yeah. Thanks. Great. Cool. Awesome. Okay, so I think we should be fine. Let's look at this way of synthesizing evidence. This is a cost effectiveness plane, where on the x-axis, yeah, we have the effectiveness of an intervention. That's where you have your health outcome. And on the y-axis, we have the cost of an intervention. So what does that mean? If we mapped out our intervention on this plane, then we would be able to determine whether the intervention is more effective and more costly than our comparator, our baseline scenario, or the intervention is less costly but less effective. This is a useful reference diagram. In most economic evaluations in health, you would find such an cost effectiveness plane in the discussion of the results. And this is the summary of this plane, effectively saying not cost effective, cost saving, cost effective in theory. Here you can see this dashed line. That is our cost effectiveness threshold, which in Kenya, as I said, could be just below 50% of the GDP. But that would be quite high. Another threshold value is willingness to pay. And now this just, I'm not going to go into much detail into this, but basically there are different cost effectiveness ratios, comparing them to the current treatment. And on the right-hand side, in the gray shaded area here, all of this would basically be cost effective, cost saving. So you would be potentially choosing this as a new intervention. Whereas anything on the top left is ineffective. So to finalize, I just wanted to chat over a quick example from the HPV vaccine in Kenya. But first, is anyone in the room on this list of co-authors? Tabitha, where are you? Where are you on the co-authors? You were part. Oh, great. Okay. If you have anything to add to what I'm saying now, please go ahead. I just read the paper and I tried to take whatever relevant information there was, but please add if there's anything. Okay. The decision to introduce the HPV vaccine in Kenya was taken in October 2019, just before the COVID-19 pandemic, which led to very low coverage in the first year. I think it was around 18%, just below 20%, incredibly low for a new vaccine. And the vaccine candidate that was chosen to be introduced was Gardasil 4. That's the Merck vaccine. But there are 3 other main types of vaccines on the market at the moment. And based on the authors of this paper, they said that the decision to introduce the HPV vaccine in Kenya was not informed by a country-led economic evaluation. That's a huge red flag for you, right? Because we want to do economic evaluations. Yeah. So let me just see. Yeah. Interestingly, I think on the left-hand side you have the 4 different types of vaccines. Excuse my pronunciation of these names. Cesulin, Cervarix, Gardasil 4, Gardasil 9. They all have different vaccine efficacy and impact on cervical cancer, because with the HPV vaccine, effectively what we want to have an impact on is the incidence of cervical cancer in the long term. You can see 2 bars, blue and orange, on this graph. They differ by the level of cross-protection to HPV types. So the main 2 types that lead to cervical cancer are HPV 16 and 18. But some vaccines cover other types of HPV as well. So you see here that Cervarix actually also, the blue bar is much higher. Cross-protection covers also, I think, 5 other types at minimum. 51, 35, I don't know the numbers. Anyhow, there's a lot of cross-protection. On the right-hand side, so on this table, this is a classic example of how you would report all of the costs associated with an intervention that you're looking at. But let's look at the simple direct costs of this vaccine. This is very clear. Gardasil 9 is the most expensive one. Gardasil 4, the one that was introduced, is financed by Gavi. So they had agreements with the manufacturer that this is always costed at $4.50. Cervarix, which does have the cross-protection to other HPV types that also have an impact on cervical cancer, costed at $5.18. Cesulin, $3. So cost minimization analysis would show you that Cesulin would be the right candidate to go for, right? Like somewhat the same outcome, health outcome, but the lowest price. Now, going to the results. They assume 2 perspectives in this analysis. The government perspective, which we didn't cover much in this talk, but I'm going to remind you of what this is, and the society perspective. The government perspective is also known as the public sector perspective. Okay. So just to cover the grounds of what these perspectives cover, the government perspective includes all the costs that are related to the diagnosis, staging, surgery, chemotherapy, radiotherapy, and palliative care. So you have the direct medical costs that would be covered in the government perspective. Then they also assumed a societal perspective, a modified societal perspective, which would include the direct medical costs, such as the supplies, non-medical costs, so for example, the patient transportation, and indirect costs, for example, patient time. Before I'm going to tell you about the interpretation of these results on these graphs, which one do you think is the most cost-effective vaccine to choose in the government perspective? Hmm? Just looking at this, look at this. So we have the incremental benefit measured in DALYs averted on the x-axis, and the incremental cost per DALY averted on the y-axis. So which one, if you think about, we want to minimize costs and maximize health outcomes. That's our objective function. I can see looks and mumbling, but I'm not hearing an answer. Any opinions you can share? Maybe just share out loud what you think. Yeah? Yeah, yeah. Mhm.
Somewhere there between, maybe it says like 450, somewhere there between 400 and 500.
Mm.
And then it's similar in terms of that Dahlia bucket. It almost looks the same as Savarix. It's sort of similar.
So which
but
one
it's
is your
celebrated.
final choice?
Second. The blue
Seculin.
one, that is what is called.
Interesting. But I mean, how about the Savarix? Like, why is it so low? It appears to have the highest incremental benefit in terms of Dahlia averted. So if we only looked at our health outcome as our decision criteria, we would definitely, well, Gardasil 9 and Cervarix are almost on the same line in terms of the Dahlia averted. Yeah? So in terms of health outcome, this is definitely the best one. But in terms of incremental cost, the top, Gardasil 9 is incredibly expensive. So let's exclude that. But the incremental cost of Cervarix is actually much lower, not much, but marginally lower than all of the three candidates on the left.
What is cheaper there, Savarix or Second?
The cheapest one is Cervarix cross protection.
Oh, okay.
Don't you think? It's the lowest one. We agree? Any objections? I mean, let me. No, it's not. So we're looking at the incremental cost, which is here. We're looking at the y-axis, yeah? So it's the lowest one on the y-axis. You see. And it's the highest one on. Yeah? And so this is from the government perspective. I'm just going to show it here again as well. So if we look at the... Are you not seeing this here? I'm sorry. I mean, if we didn't have this one, then we would, then it would be very difficult to see. Fine. But we have this one, yeah? Okay, so we have, in terms of, on the y-axis, it's lowest here, and on the x-axis, it's highest here. Okay, cool. I'm almost done.
From here.
Smart,
But
yeah.
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 Yes.
Nice.
So I think it will be easier.
Yeah, okay.
Yes.
So you see at the red circle now, yeah? This is one candidate. The co-authors of this paper decided that they're gonna, just going back to this, we have the cross protection, yeah? So there are 4 candidates to compare, but we see 5 points on this diagram. The 4, basically what they decided to do is to add one more scenario where they would also test the cost effectiveness of the cross protection. Because the other ones are so similar to each other, the cross protection and no cross protection, they decided not to include those in the analysis. This is why cross protection would naturally lead to better health outcomes, but it also shows that the incremental cost benefit of this is more favorable, leading to the recommendation of introducing Cervarix. The same conclusion can be taken from the societal perspective. Yeah? If you think back to the decision-making plane here, it's exactly the same. We see on the y-axis, we have the cost of the intervention, and on the x-axis, we have the effectiveness of the intervention. So in the diagram of this publication, we basically cover, it's very hard to write with this. this area of the graph. Yeah, and our Serverx example is actually in the cost-saving panel. Okay, then we briefly touched on the willingness to pay, and I think they did a very interesting part of this analysis was looking at the willingness to pay. Their threshold, what they did is they took 10% of the GDP per capita. Okay? So I mentioned before that you can do 50% if you don't have the information. They used 10%, but in their sensitivity analysis, they also considered 50%. They did everything, I believe, from 10 to 50%. Okay, so what they did in this graph, they looked at the probability of the candidate to be cost effective and mapped this against the willingness to pay threshold. And based on this graph, the probability that the candidate is cost effective is here at a willingness to pay of just under $100 per DALI averted. Why we don't? You have 5 minutes left. Great. I'm great. I'm at the end of my presentation. But yeah, so this is an interesting way on identifying the willingness to pay. I think in general, I would highly recommend you to read this paper by Lucy and she's got it all. No, but it covers a lot of the principal topics of economic evaluations that we covered today in an applied setting. I really like the paper. There are some things as a health economist that I would have potentially done different, but I think there is always, you always have preferences as a health economist on which costs to include or exclude. So I think that was interesting. Yeah, I have included here some other interesting examples of health economic evaluations that were done in Kenya. This one here by Dr. Mwai, and the other ones done by other research groups. All of them assume different perspectives and just give you a different touch on economic evaluations. These are some further resources if you wanted to learn more about economic evaluations. Some of them are primers, so really introductory papers to economic evaluations. I think they all should be open access, so any of these links should work. And I think that's it. I made it on time. Thanks, AI. Okay.
The information has sunk in very well. All right.
Great.
Thank you for your time and for that insightful presentation. Timekeeper, give us guidance. Good morning. Tell us which way to go. If you say left, we'll go left.
Yeah. I think from our program, we are 1 hour late. So we'll go for tea for 20 minutes. And for the next presenters, I want to request like you use 45 minutes so that we can be able to cover the 1 hour that we are late. So that by today, we should be as per the program.
Thank you. We didn't do evaluation for yesterday's work because I finished this morning. So at some point, maybe when you're having our lunch break, I'll request that we provide course evaluation for day 2 as well. And then those who came after we started, we had an announcement about filling the form for dinner. Kindly fill it in, whether you'll be in or not, so that we're able to know. If you're not coming in for dinner, kindly just say no, so that we are sure that you did miss the form, but you'd like to join us. All right, thank you. Enjoy your tea.
You have 20 minutes. 20 minutes as
come and show you something. Our 20 minutes has started. We are going. Kuja nikwambie kwa